Hello everyone. So today our topic of discussion is recent advances in respiratory distress syndrome in preterms. So we'll discuss only practical points, we'll not go in theoretical details. So today our agenda of discussion is antenatal steroids, delivery room management in preterm babies, non-invasive ventilation, HFNC, CPAP, NIV, synchronized NIV, surfactant administration, caffeine, and postnatal steroids. First, coming to antenatal steroids. So, antenatal steroids have drastically changed the outcomes in preterm babies or newborn outcomes. So, recommendations of ACOG recommendation of antenatal steroids are we have to give antenatal steroid to mothers between 24 to 34 weeks of gestation and who are at risk of the preterm delivery in coming 7 days, or after 34 weeks up to 36 plus 6 days, means late preterm baby is also ACOG recommends single course of steroids that will reduce risk of TTNB, respiratory distress, or NICU admissions. So ACOG recommends to all between 24 to 34 weeks, and we can give between 34 to 36 plus 6 days also a single course, and between 22 to 23 weeks and 6 days we have to discuss with family if they want to go with aggressive resuscitations and you have facilities in your NICU to manage these micropremies, then we can give before 24 weeks also up to 22 weeks a single course of antenatal steroids if we are expecting delivery in coming 7 days. And repeat course of steroids, ACOG recommends that one repeat course we can give if previous course was given 2 weeks prior. So if 2 weeks already have lapsed and baby is still 34, less than 34 weeks, then we can give one more course of antenatal steroids in these babies. Okay. Now coming to RCO's recommendations, RCO's is between 24 to 34 weeks is same if we are expecting coming 7 days. And RCO's recommends in late preterm or even term babies also if we are doing elective LSCS. So RCO's recommends we can give up to 38 weeks and 6 days. Means before 39 weeks also if we are going for elective LSCS, we can give one course of antenatal steroids in these babies. And as 22 to 23 weeks and 6 days, discuss with family. Repeat course, RCOC does not recommend repeat course of antenatal steroids. So repeat course is only recommended by ACOG, not by RCOG. ACOG recommends maximum up to before 37 weeks, and RCOG recommends before 39 weeks also. What to do for babies less than 22 weeks? Can we give antenatal steroids? So before 20 weeks, antenatal steroids are not recommended because here alveolarization also not started. So alveoli are not there, then how antenatal steroids will increase production of surfactant. So before 22 weeks, not recommended. Coming to dosing, so dexamethasone dosing is 6 milligram 12 hourly 4 doses. 6 milligram 12 hourly, total 4 days doses. So total 24 milligram IM. Betamethasone also is 24 milligram, but 12 milligram 12 hours apart. So 2 doses are required only for betamethasone. So which one is better? Both are efficacy-wise, both are same, but betamethasone, because we can complete one full course within 24 hours. We give one dose today, and after 24 hours tomorrow, second dose, and then we can go for delivery. So here course is completed in 24 hours, but here course is completed in 48 hours. So this is better for completion of course, but efficacy-wise both are same. But dexamethasone is cheaper, easily available. So most people are following dexamethasone 6 milligram 12 hourly 4 doses. Both are 24 milligram IM injection in gluteal region. So we can efficacy is same, but dexamethasone is easily available. But betamethasone, that salt is recommended is phosphate and acetate combination that is not available in India. Okay, so dexamethasone most people are using. Can we give hydrocortisone? So hydrocortisone is not recommended because hydrocortisone does not cross placental barrier. So hydrocortisone is metabolized by placental enzymes. That's why it is not recommended as a antenatal steroids. Coming to contraindication, only one absolute contraindication is the frank chorioamnionitis. If mother is in frank chorioamnionitis, features of chorioamnionitis are there, then it is absolute contraindication for antenatal steroids. Otherwise, no other contraindication we should give in all mothers who are going to deliver preterm baby. Actually, diabetes and hypertension also are not a contraindication. If any mother is having uncontrolled diabetes or uncontrolled hypertension, then we can consider as a relative contraindication, but not a absolute contraindication. We can give in diabetic mother and PIH mothers also. Now coming, what are the evidence-based benefits of antenatal steroids? So antenatal steroids have changed the neonatal outcomes drastically because they reduce so many neonatal mortality and morbidities. Like the antenatal steroid reduces the risk of a perinatal death and neonatal death. Perinatal period and neonatal period, they reduces the risk of mortality, reduces risk of the RDS, reduces risk of the intraventricular hemorrhage, NEC, reduces need of the surfactant after birth, and reduces need of mechanical ventilation. So many benefits are there, and that Cochrane logo, you can see that this Cochrane logo is there. That also is taken from the meta-analysis of the antenatal steroids. So meta-analysis of Cochrane, this is the logo of meta-analysis of antenatal steroids. So Cochrane has taken from that only. So it means antenatal steroids are that much important, and they have changed the outcomes drastically. Now coming to after antenatal steroids, now coming to delivery room. So how to manage these RDS preterm babies in delivery room? First, start early CPAP, delivery room CPAP in these babies. So if any baby less than 28 weeks, in these babies, we can start even prophylactic CPAP also before starting respiratory distress. Start CPAP in delivery room itself. If babies are more than 28 or more than 30 weeks, then we can start early CPAP. If babies having some form of respiratory distress, so start delivery room CPAP, early CPAP. That will reduce the risk of alveolar collapse, and that will maintain the FRC. And if baby needs any resuscitation, then don't use ambu bag. Use T-piece resuscitator, because ambu bag does not have PWP, and we cannot deliver a regulated control PIP from the ambu bag. So risk of volutrauma, barotrauma, lung injury will be higher with ambu bag. And but in T-piece we can deliver regulated PIP, and PEEP also we can deliver with T-piece resist. So use T-piece resist always. Even for delivery room CPAP also we can give through T-piece resistor. So in every delivery room we should have T-piece resistor. Next is give titrated FiO2. Do not resuscitate babies with 100% FiO2. Give titrated FiO2. For that, we need to have blender in the delivery room. So in delivery room, we should have blender. We should have TP resistor, and we should have humidifier also. So we should give heated humidified air to these babies. Heated humidifier oxygen to these babies for resuscitation or for CPAP, and titrated FiO2 to target the target saturations and temperature maintenance. If baby is less than 32 weeks or less than 1.5 kg, then we should have polythene wrap, and do not dry these babies and cover with within polythene wrap to prevent the evaporative heat loss these babies, to prevent hypothermia, because temperature maintenance is very important in these babies. If babies goes in hypothermia, even 1 degree Celsius also increases risk of a mortality in these babies. So this is about delivery room management. So in delivery room CPAP, one trial was done, COIN trial. COIN trial means CPAP or intubation. They have divided in two groups. One group they have given delivery room CPAP, second they have intubated and ventilated. In extreme preterm babies between 25 to 28 weeks, and they found that there was no difference in death on BPD, but use of surfactant was reduced by 50% in delivery room CPAP group. And so need of surfactant was less, even 50 reduced by 50% in delivery room CPAP group, but pneumothorax was higher in the CPAP groups. So that we can manage with proper monitoring and proper CPAP delivery. That can be managed, but surfactant use was less. This meta-analysis was done of the 4 landmark trials: COIN trial, support trial, VON-DRM trial, and CURPAP trial. So these 4 RCTs, they have done meta-analysis. They have these all 4 trials, they have compared nasal CPAP versus intubation. So CPAP versus intubation they have compared, and this meta-analysis was done of these 4 trials, and they found that there was reduction in BPD, reduction of BPD at 36 weeks. We can see relative risk is 0.89, means reduced by 11%. BPD risk was reduced by 11%. Death or BPD combined also they have reduced by 11%. Reduction in the mechanical ventilation, need of mechanical ventilation was reduced by 50%. So if you start delivering super, need of mechanical ventilation will reduce by 50%. Use of surfactant was reduced by 46%. RR is 0.54, means reduced by 46%. So BPD was less, death was reduced, need of mechanical ventilation, hence use of surfactant was less in delivery room CPAP group. So delivery room CPAP is now a standard practice, early CPAP, delivery room CPAP, that will reduce need of mechanical ventilation, need of surfactant also. Next, coming to what interface we should use for CPAP delivery. So many interfaces are there: short binasal prongs, RAM cannula. This is the Hudson prong. This is short binasal prong. Argil prongs, nasal mask. So these Hudson prongs are commonly used. They are easy to use, and nasal septum injury risk is there, but not much. And fixation problem will be there sometimes. Ram's cannula fixation is very easy. Handling is very easy. Nasal injury risk also is very easy. But here, pressure delivery is not as good as other devices, other interfaces. So here, because it's sometimes not snugly fitting, and it is we can use for HFNC, but for CPAP delivery, pressure delivery is not as good. For short binasal prongs, for fixation it is good, but here risk of the nasal septum injury is very high, because it will cause pressure on the nasal septum and that cause injury. So short binasal prongs, nasal septum injury is very high, but in nasal mask, injury will be at the root of the nose. So here we can see, here is the root of the nose. This is the nasal mask, and here root of the nose, pressure will be at the root of the nose, and here injury will happen in nasal masks. But in this is the short binasal prong, here injury will happen at the nasal septum. Here with short binasal prongs, fixation is easy. Here also fixation is easy, but sometimes leak will be there. If babies moves, then leak will be there. Okay, so we can use nasal mask or Ram's cannula, easy to fix, and injury risk also is less. So we have to monitor for injury. So grades of injury are there. If redness is there, there's grade 1 injury. If some superficial breach is there, grade 2, and grade 3 is if deep breach is there. So if we have to detect at stage 1 only we have to detect if redness is there, then we have to see what can be done. Otherwise it will progress and it will cause like nasal septal injury, complete columnar septal collapse, septal erosion. These injuries can happen. So we have to be watchful. So how to prevent these nasal injuries? So first we have to select proper size of nasal prongs or mask. This should be just snugly fitting, should not over distend the nares or should not be loose also. So just snugly fitting. Proper size prongs or masks we should select. Second, heated humidified gas we should deliver. Otherwise that secretions will be dried and that will cause nasal injury. There should be some 2 mm gap between the nasal prongs and the nasal septum. It should not be tightly fitting, otherwise it will cause pressure and cause pressure injury. So some 2 mm gap should be there between the nasal septum and the prongs. We can use skin barriers like Tegaderm, Geoderm or cannulates to prevent the pressure injuries, but sometimes these also are not effective. We have to be watchful. Pressure release technique we can follow in every shift, sometimes for few seconds, so we can release some, we can loosen it up and we can release the pressure. Local massage we can do to increase the microcirculation of local skin and tissues. Proper monitoring is very important. Every shift we have to see for nasal injury and we have to record if there is any redness or injury is there. If there is an injury, we can alternate between the prongs and mass. That will change the pressure points and that will prevent the further increase in injury. So these points we can follow to prevent nasal injury. Coming to the non-invasive ventilation. So we have so many options: CPAP, HFNC, NIPPV, synchronized NIPPV, now coming into nasal HFO also. So if we compare between CPAP or HFNC in preterm babies, which one is better? So if any newborn baby having parenchymal disease, alveolar disease, alveoli are collapsed like RDS or pneumonia, then always CPAP is better because that will deliver pressure, that will open up the alveoli. So any parenchymal lung disease, CPAP. If airway disease are there predominantly, then like bronchiolitis, HFNC is better. So if any in term babies, CPAP and HFNC are equal. There is not much difference in term babies. If we are using as a primary respiratory support or post-extubation, we can use CPAP or HFNC, both are equal. But in preterm babies, as a primary respiratory support, in preterm or in extreme preterm babies like less than 28 weeker or less than 1 kg preterm babies, as a primary respiratory support, CPAP is always better because CPAP failure is less as compared to HFNC. So as a primary respiratory in extreme preterm babies, CPAP is better. But in more than 1 kg or slightly bigger babies, you can use HFNC also. Nasal injury is always less with HFNC. Fixation is better. And handling also is better with HFNC. Second, if you compare between CPAP or NIPPV, in this NIPPV is always better for as a primary respiratory support for RDS also is NIPPV is better because that will reduce risk of intubation by 20% as compared to CPAP, reduces the risk of intubation by 20%. If you are using post-extubation also is the NIPPV is better, reduces the extubation failure. So NIPPV reduces the extubation failure as compared to CPAP. In apnea of prematurity, also, if baby is having recurrent severe apnea, then NIPPV is better for apnea. So for primary respiratory support, for a post-extubation and apnea of prematurity, all three, NIPPV is better than the CPAP. Risk of the failure is less with NIPPV as compared to CPAP. And if you use synchronized NIPP, that even more better, that will increase the efficacy of NIPPV if you are using synchronized NIPP, but that is available in very few ventilators and few machines like in SLE 6000 has synchronized NIPP. I think VN 600 ventilator also have synchronized NIPPV, and some few standalone machines are there for an IV like Freedom Plus have in that also have that synchronized NIPP. So it's synchronized NIPP is even better than NIPP. If we should avoid invasive ventilation as far as possible, if still we have to do invasive ventilation, then what are the things we should follow? So always use synchronized mode. Patient triggered ventilation means synchronized mode should use, like SIMV or assist control or PSV. We should not use IMV. So synchronized mode we should use. In that also we should use the mode that supports every breath, means assist control or PSV mode. So we should use synchronize, and that mode that supports each breath we should use in invasive ventilation, because synchronize in that baby will be more comfortable, airway pressures will be less, and asynchrony will be less, and risk of the IVH also, risk of the pneumothorax will be less with the synchronization, and weaning will be faster with synchronized mode. Second, in preterm babies, use volume targeted ventilation. That in previous lecture we have discussed all about volume targeted ventilation, like volume guarantee, PRVC, TTV. That is the volume targeted ventilation, best mode for the preterm RDS babies, because here auto weaning will be there. So ventilator induced lung injury will be less in volume targeted ventilation, and so many benefits are there that we'll discuss. Next, open lung strategy. We should follow open lung strategy in preterm babies. Okay, so we should recruit the alveoli. We should recruit the alveoli and keep open the alveoli. So we should give adequate PEEP. Adequate PEEP we should give to open up the all of the alveoli. If alveoli are collapsed, that will increase the risk of the atelectotrauma, volutrauma, biotrauma. So that will increase risk of the BPD. So follow open lung strategy, open lung ventilation. Next, permissive hypercapnia. Permissive hypercapnia we can follow if pH is maintained above 7.2, then we can accept PCO2 up to 55, or sometimes 60 also people say, or up to 55 we can accept. If pH is maintained, baby is comfortable, and baby is not in shock, then we can accept permissive hypercapnia. Because if you want to achieve that CO2 less than 45, sometimes we have to over ventilate baby, sometimes we have to give more tidal volume or more pressure, that will increase risk of volume ventilation induced lung injury. Follow target saturation between 91 to 94%. We don't want above 95 also, or we don't want below 90 also. So follow target saturations. And early extubation. So in invasive ventilation, use synchronized mode, volume targeted mode, open lung ventilation, permissive hypercapnia, target saturation between 91 to 94%, and early extubation to NIV. So volume guarantee we have discussed already, reduces the risk. It's very important. Preterm babies reduce risk of mortality, BPD, pneumothorax, IVH, PVL, hypocarbia, and duration of ventilation also is less with volume targeted ventilation. Now coming to surfactant in preterm RDS. So what is the indication of the surfactant? If any preterm baby has come, we have already started baby on CPAP, and we can start for 5 or 6, and accordingly, if still restrictions are there, we can increase the CPAP. If baby is on CPAP having FI to require more than 30%, that is itself an indication of the surfactant. So new European guideline says if FIT requirement on CPAP is more than 30%, just give surfactant. Don't wait for X-ray also. No need for X-ray to give surfactant. Second indication, if baby is requiring intubation in delivery room for stabilization or resuscitation. If baby is required intubation itself in delivery room, first of all, do not intubate. But if still having baby is not having any respiratory efforts, or baby is having requiring resuscitation, in that those babies we can give surfactant. We can give surfactant in delivery room itself. Second indication of repeat course. Repeat course, if after one course also baby is having high pressure requirement or FIT requirement, then we can give one repeat course of surfactant. after 6 or 12 hours. So these are about indication of surfactant in preterm babies. So when to give surfactant? Three strategies are there: prophylactic, early rescue, and late rescue. So prophylactic nowadays we are not following. That is done within before 30 minutes of birth, before developing respiratory distress. So previously we thought that we should give before developing respiratory distress, because in that time alveoli are not collapsed and their lung fluid will be there, that will help in spreading the surfactant, that will cause better result. But we found in studies that risk of mortality was higher if we are giving prophylactic surfactant, and many babies who would have improved on CPAP itself, that ended up receiving surfactant. Surfactant giving also is a invasive procedure, so we should avoid prophylactic surfactant before developing respiratory distress. We should not give first start delivery room CPAP. Still babies having more than a 5 to more than 30%, then we can give early rescue surfactant within 2 hours. So nowadays we are not following prophylactic, we are following only early rescue surfactant. Within 2 hours we should give. That will lung fluid will help spreading surfactant, and we are giving before widespread atelectasis develops. Late rescue also we are not following. If any outborn baby is coming after 2 hours, then we can give. Otherwise, inborn babies should give early rescue surfactant. Different brands are there. NICU 5 ml per kg is the dose. Available vials are 3 ml and 5 ml. Now rate has increased, I think 11,000. Surventa is 4 ml per kg dose. 2 vials 4 ml, 8 ml are available. CURPAP is 2.5 ml per kg. 200 milligram per kg is the dose of the CURPAP. We are giving by double dose. 100 milligram versus 200 milligram per kg is better. So we are giving 200 milligram per kg, 2.5 ml per kg. Available vials are 1.3 ml and 3 ml. This is slightly costly. CURPAP, this amount is very less. So here, this one is better for Lisa, because here its place will be less. But some studies says that 200 milligram per kg CURPAP is more efficacious. Okay. For currently commonly available NICU, Surventa, some people are using CURPAP also, 2.5 ml per kg. Okay, and okay. So now coming to methods of administration. So method of administration are: IN-SUR-E is the most common method people are following. IN-SUR, intubate, surfactant, give surfactant and extubate. Second, IN-REC-SUR. IN-REC-SUR means intubate, recruit the lungs by HFO, and give surfactant, then extubate. Here we are just intubating, giving surfactant, and immediately we are extubating to CPAP. Here just we are intubating, we are recruiting the lungs by HFO, so that all the alveoli are recruited, and then if you give surfactant, that will be spreaded in the all the alveoli. That will should result in better outcomes. But nowadays we are not following, because this one also is invasive ventilation. We should not follow invasive. We are going towards the non-invasive. So these are the invasive. So now coming to Lisa or mist. This is less invasive surfactant administration. Here we are not intubating the baby. Baby is on CPAP. Just we are under the laryngoscope. We are giving surfactant directly on the CPAP only. Baby is breathing spontaneously on CPAP, and we are giving without intubation with the thin catheter, surf cath or angiocath. LMA, laryngeal mask airway. Here also slightly non-invasive technique, but still some studies require in this. Nebulization method also is not following. So currently we are following mostly commonly IN-SUR and Lisa method. So coming to IN-SUR method, how to give? So first we have to warm the surfactant in hands or in the room temperature. Do not heat, do not shake. We should not shake, just keep in the hands to warm it up. Check the ET position is correct. Then in ET tube, we should insert the feeding tube and give in 4 aliquots. Baby head should be in midline. There is no need to change in the positions of the baby. We can give in 4 aliquots, so spillage should not be there. And we should connect the TPC or ventilator. We should not use AMBU bag here also, because AMBU will not provide the PWP. If there is no PWP, the alveoli will be collapsed and surfactant will not be spreaded in the collapsed alveoli. So use TPC resuscitator, or you can connect directly ventilator. So PEEP will be there, that better spread will be there. And extubate immediately after or within 1 hour, you should extubate in IN-SUR-E. So this is the method of IN-SUR-E. Coming to LISA, less invasive surfactant administration. For that, we need one surfcath or surfactant catheter, syringe, this Megel's forceps, and laryngoscope. Baby is currently on CPAP. No intubation is required. Continue on CPAP. Insert catheter into the trachea with laryngoscope. Surfcath, angiocath, or feeding tube also we can use. And administer surfactant through the catheter. So what are the evidence-based benefits of the LISA? So in extreme preterm babies, we should follow the LISA technique currently to reduce the risk of BPD. So Cochrane says that LISA method reduces the need of ventilation, reduces risk of the BPD and mortality. So reduces risk of the mortality, BPD, and need of ventilation. These are the evidence-based benefits of LISA. So we should follow in extreme preterm babies only LISA technique for surfactant administration. So according to Cochrane, between prophylactic or selective. So we should not give prophylactic surfactant. We always should give selective early rescue by LISA technique. Extreme preterm babies, we should follow LISA. Natural surfactant we are following currently, natural surfactant. Single or multiple, if required, give multiple doses. That will reduce risk of the mortality, and even pneumothorax also are less with if you are giving multiple doses if required. Okay. Coming to caffeine. So caffeine we are giving in less than 32 weeker babies. We start from day one also. So caffeine we are not giving only for apnea. We are giving for neurodevelopmental outcomes. So in less than 32 weeker babies, start from day one only. Loading dose 20 milligram per kg, followed by maintenance 5 to 10 milligram per kg per day. You can start 5. If still baby is having apnea or desaturation, we can go up to 10 milligram per kg OD doses. So what are the evidence-based benefits of caffeine? Caffeine also reduces the risk of the BPD, facilitates early extubation because it improves the respiratory drive and reduces the lung inflammation also, and causes diuresis that will facilitate early extubation. Because of the early extubation, there is reduced risk of BPD also. Reduces the risk of extubation failure. So before extubation, if your baby is not on caffeine, in preterm baby, we should always load with caffeine, then only extubate. That will reduce risk of the extubation failure. Reduces the neurodevelopmental impairment at 18 to 24 months of age. So that is very important in preterm babies. So what are the indication? If baby having preterm baby less than 32, start from day one. Or if baby we have not started, baby is having apnea, then we can start. Okay, so for neurodevelopmental outcome also, we should give caffeine in preterm babies. Coming to postnatal steroids. So postnatal steroids, we are giving, we should not give postnatal steroids in first 7 days of life. So first week of life, we should avoid postnatal steroids, because in first week of life, steroids will lead to neurodevelopmental impairment. So first 7 days, we should not give. We have to give postnatal steroids if any preterm baby is ventilator dependent. Even after 1 week of life, baby is on ventilator, we are not able to wean the baby, we are not able to extubate the baby from ventilator even after 1 week of life. So in second week of life, we can give and postnatal steroids. Low dose dexamethasone DAART regimen is there. DAART regimen we can start in these babies. That will facilitate extubation of the baby. That will reduce the risk of the baby. So postnatal steroid we are using as a prophylaxis of the BPD and treatment of BPD also. So in these babies, if we are using in second week of life, that we are using for prophylaxis of BPD. And if later on after established BPD, if we are using postnatal steroid, that is for treatment of the BPD. So in second of week of life, we are using to facilitate extubation and to reduce risk of the BPD. So finally, coming to take home message. So in preterm babies, we can start from before delivery room. First is antenatal steroids should receive baby. All the babies before 34 weeks should receive antenatal steroid. Second, if baby is less than 32 weeks, that baby should receive max self also. That will also improve neurodevelopment outcome. That will reduce the risk of the cerebral palsy. So first, antenatal steroid. Second, max self. Third, delivery room CPAP, early CPAP, delivery room CPAP. Avoid intubation and invasive ventilation. The next, early rescue surfactant. Within 2 hours, give early rescue surfactant, and better to give by Lisa technique. Better to give by Lisa technique. Then, when to give surfactant? If on CPAP, if I to go more than 30%, use TPs or delivery room CPAP. Repeat dose if required. Start from day one caffeine and do not give antenatal steroid in first week of life. So these are the points. So today we have discussed all about from preterm babies, RDS, what are the recent advances in the management of the RDS, and we have touched all the practical points, I think. So all the guidelines what we should follow nowadays that we have discussed. Thank you so much.